Executive Officer, and Dr. Bradley Wooters, Representative and Executive Vice President for Science and Research at the University Health Network. From the Heart and Stroke Foundation of Canada, we have Anne Simard, Chief Mission and Research Operator. With that, we will start with Mr. Dean. Mr. Dean, please go ahead with your statement. You have 10 minutes, please.
Good afternoon, Mr. Chair, members of the Standing Committee on Health, and invited guests. Let me begin by thanking you for the opportunity to appear before you today. My name is Terry Dean, and I'm the President and CEO of the Canadian Lung Association. I'm delighted to be joined by Dr. Mohit Bhutani, a respirologist and professor of pulmonary medicine at the University of Alberta. Today, I'd like to tell you about the Canadian Lung Association, how we've adapted to respond to the current respiratory pandemic, provide you with a perspective of the specific challenges facing those living with lung disease, and share with you what we need in order to continue to carry out our mission. The Canadian Lung Association is the country's leading organization focused on helping Canadians breathe. We do this by funding research, leading advocacy, and providing up-to-date health information for all Canadians. We represent the 1 in 5 Canadians who live with lung disease, and these are among the Canadians most at risk for developing a severe case of COVID-19. However, we also represent the 5 in 5 Canadians who simply need to breathe on a daily basis. This year, we celebrate our 120th anniversary as an organization. Given the current situation, we're compelled to reflect on our founding in 1900 as an organization created to address another respiratory pandemic, tuberculosis, often referred to as TB. We made a significant and valuable progress during that difficult time of our history and have helped to create solutions for prevention, testing, education, as well as treatment of TB. We're confident we have a similarly valuable role to play now, 120 years later. However, we find ourselves in the midst of a new respiratory pandemic, COVID-19, and our organization and our work has never been more important. When you can't breathe, nothing else matters. No one knows that better than the 6 million Canadians already living with lung disease. We know these individuals are at the greatest risk of severe symptoms from COVID-19, including the need for hospitalization and treatment within intensive care units, and even death. Beyond the very real increased risk, individuals with lung disease are also faced with increased health anxiety. Many are concerned about properly identifying symptoms of COVID-19 and differentiating them from their existing lung disease. They have questions about how to continue their treatments, access medications, and keep themselves in the best health possible. Finally, their caregivers, friends, and support networks need to know the best ways of keeping them healthy and safe at the same time. We've heard their collective voices of concern and have answered the call. We're doing our part to help Canadians understand COVID-19, prevent its spread, and protect themselves. We've created a unique suite of resources and tools to help them get the information they need. We've hosted a webinar linking patients to respirologists and healthcare professionals to help them understand the specific impact that COVID-19 may have on them. We've created a series of FAQ videos that address the nuanced questions people have about smoking and vaping, as an example, in COVID-19, advice on medications and use of action plans, as well as how their specific lung disease will be affected by COVID-19. Finally, we deployed more resources so that our toll-free helplines can answer the increased calls the patients have on a daily basis. As we put the patient first, we find ourselves doing more with less as we adapt our programs and resources to respond. We also fund critical lung health research, and we help develop early career investigators. If we're unable to continue to fund them, we risk not keeping them in the field of research at all, which will have profound long-term consequences on lung health. From improving treatment options to enhancing quality of life, or aiming to reverse or cure certain diseases, our researchers are working diligently to help all Canadians. Together, our programs and their research put the air back in the lungs of all Canadians. Yet during a time when we are being asked to do more, our sector is struggling. The COVID-19 pandemic has presented unprecedented challenges for the healthcare system and health charities across the country. The funding the government has provided thus far is greatly appreciated and provides some relief to some health charities. However, it is not enough to sustain them through the pandemic and into the future. Canadians rely on health charities and will need our organizations to come out of this strong and ready to continue to deliver on the mission we've promised to carry out. The Lung Association is a member of the Health Charities Coalition of Canada, which represents a $670 million industry with 2,500 employees and almost 3 million patients. As a coalition, we need more support from the government to help us close the gap of revenue dollars to maintain our operation so we can get back on our feet and ensure that we not only make it through the pandemic, but we remain strong afterward. In closing, I want to thank the committee again for the opportunity to appear before you today. COVID-19 is a respiratory pandemic, and the Canadian Lung Association has never been more important. We ask the committee to consider the recommendations on further financial support for the charitable sector to ensure Canadians continue to get access to the services and support they need today, but also into the future. Now I would like to introduce you to my colleague, Dr. Brittani, who we invited with us today to demonstrate how we work in partnership with medical experts to help meet patients' needs. We'll be happy to answer any questions afterward. Dr. Brittani.
Thank you, Terry, and thank you to the Standing Committee on Health for the opportunity to appear today. I join you today to represent the partnership between the Canadian Lung Association and the Canadian Thoracic Society. The Canadian Thoracic Society, or CTS, is Canada's national specialty society for respirology. We are an interdisciplinary professional association of healthcare practitioners that includes physicians and a wide range of healthcare professionals from across the country. As the COVID-19 pandemic began to spread around the world and in Canada, healthcare professionals and patients with lung disease began to ask questions about how best to manage their conditions under this new reality. Health professionals asked questions regarding how to manage acute and chronic lung symptoms, which medicines were safe to prescribe to patients, were there any medicines that perhaps they shouldn't prescribe to patients during the pandemic? Similarly, patients were asking us questions about what they could best do themselves to protect themselves during the pandemic. Should they visit their doctors? Should they go to the emergency room or to the hospital in case they need to? How do they know if they have had a COVID-19 infection? As the medical and scientific authority in lung health, the CTS and its members are ideally suited to guide Canadians through this challenging and unprecedented times. The Canadian Thoracic Society is Canada's leader in the development and dissemination of evidence-based clinical practice guidelines. This work is strengthened by our partnership with the Lung Association, who then translates these guidelines into public and patient educational materials and programs. Our collaboration allows the patient to access the most up-to-date evidence-based information and medical expertise on issues impacting their lung health. Since the pandemic began, the Canadian Thoracic Society has been extremely active in developing and disseminating documents on best practices for lung health in the time of COVID-19. Thus far, we have developed a website that is accessible by anyone. We've developed clinical guidance for the optimal management of asthma, COPD, also known as chronic obstructive pulmonary disease, which is the #1 cause for hospitalizations across the country, and sleep disordered breathing. We've collaborated with Health Canada, the pharmaceutical industry, and various associations such as the Canadian Medical Association and the Canadian Pharmacists Association to develop a mitigation strategy for patients and clinicians in the event of an inhaler shortage, primarily speaking about a drug named salbutamol, which is a rescue inhaler used commonly by many patients. And we're about to publish recommendations on intensive care unit triage thresholds for lung conditions like COPD and cystic fibrosis to assist healthcare providers and health systems in decision-making in the event of a major surge in hospitalizations. The partnership with the Lung Association has been critical as they've adapted these evidence-based recommendations and created educational infographics for patients with asthma and COPD to provide really in plain language guidance on managing their condition during COVID-19. For Canadians living with lung disease, there's never been a more important time to make certain their condition is well controlled. This is not only important to them for their well-being, but also for the well-being and the protection of our health systems. our partnership between the CTS and the Canadian Lung Association really gets the best evidence into action. I'm very pleased to be here today to support the initiatives of to help support Canadians during this respiratory pandemic. And we need to ensure health charities such as the Canadian Lung Association can continue to offer these critical services now and into the future. Thank you.
Thank you. I see that Mr. Theriault has his hand up. I understand you're having some difficulty with the French. I understand it's being worked on. Are you okay? I'm not hearing Mr. Theriault at all, or the translation.
Mr. Chair, I'm not hearing anything either.
Yeah, Mr. Theriault, can you try speaking again? We're not hearing you at all. You're not muted, but
Oui,
check.
hello?
Ah,
Oui.
oui.
Hello, hello, can you hear me? I was trying to take off the mute. Mr. Chair, I didn't want to interrupt the witness, but the sound coming from the interpretation is very crackling. We can hear, we can follow the interpretation, but there is a background sound with the sound of interpreters. It's intolerable. Last time we said that we should put cell phones further from the mics. Maybe it's the fact that the interpreter is speaking too close to the mic. I can confirm that the interpreter is not speaking too close to the mic.
I'm told that the technical matter has been addressed. Hopefully that has been fixed. If you continue to have problems, certainly you can unmute and indicate that you have a point of order. If necessary, we will suspend and have technical work on it again. But having at this point, I believe it's rectified. We will carry on now with the Canadian Cancer Society. Ms. Seal, you have 10 minutes, please, for your statement.
All right, thank you. Good afternoon. Thank you, Chair, and thank you, committee members, for having us here today, and thank you to my fellow witnesses. I'm speaking from Vancouver, the traditional territories of the Coast Salish people, the Musqueam, Squamish, and Tsleil-Waututh. And my name is Andrea Seal, and I'm the CEO of the Canadian Cancer Society. And I'd like to share with you today the perspective of one of Canada's largest health charities, and to share the experience of cancer patients during the pandemic. I think it goes without saying that the pandemic is testing us in more ways than we ever thought possible, and that we're rising to the challenge on many fronts. It's exposed vulnerabilities and sharpened focus. I'm really happy to see that all the people who support our most vulnerable have really taken a rightful place as real life superheroes, and our healthcare system is evolving quickly, and elected officials such as yourselves and governments across the country have really shown incredible leadership for our country. Canada's charities, and of importance for this committee, Canada's health charities are in a very dire situation. It's estimated by Imagine Canada that registered charities in Canada will lose between $9.5 and $15.7 billion, and will lay off between 100,000 and 200,000 staff as a result of the pandemic. And job losses in occupations in the nonprofit sector are already 1.4 times higher than in the rest of the economy. The Canadian Cancer Society is one of the largest charitable organizations in the country, and I can truly say that this is the greatest financial challenge we've faced in our 80-year history. We're just youngsters compared to the Lung Association. The hundreds of fundraising events that we've had to cancel across the country have led us to forecast a drop in donations of between $80 and $100 million in the year ahead. That's roughly half of our budget. We've laid off more than a third of our staff, and we've closed community offices across the country. And with projections that the downturn will continue for some time, we're being forced to reduce our services and our support for cancer research funding. The pandemic is also having an incredible impact on cancer patients and the caregivers that we represent. And of course, the reality is that cancer doesn't stop being a life-threatening, life-changing disease in the middle of this global health crisis. You may know that more than 1 million Canadians are living with and beyond cancer. They're among the most vulnerable in our communities right now because they rely so heavily on the healthcare system that's forced at the moment to turn them away. They rely on community organizations that are overwhelmed, and they rely on a support system of their friends and family who must also stay away right now. In the words of one cancer patient, she said, "I feel like I'm on planet leukemia and the rest of the world is on planet COVID, and I'm not certain where Earth is anymore or if I'll ever get back." For a sense of the scale of this challenge, 1 in 2 Canadians will be diagnosed with cancer in their lifetime. And when you or someone that you love has cancer, and many of you probably know this from personal experience, your sense of time is different. It's measured in hours or in days or in weeks, and it's measured in the visits to your doctor or the number of times that you're going to be able to hug someone that you love. And as we delay these activities in the name of social isolation, imagine how hard it is for someone with cancer to wait. Clinical trials have stopped in many cases. Radiation, chemotherapy, and surgeries are postponed. And there are those who haven't yet been diagnosed and are waiting to find out if they have cancer. Almost 250,000 Canadians are diagnosed with cancer each year. And right now, they're left to deal with their anxieties and fears, not knowing when they're going to begin treatment and hoping that their cancer hasn't spread. And we know that when the pandemic is over and we're getting to see some light at the end of the tunnel, there will still be a backlog to our healthcare system of many months or perhaps years still to come. During all of this, the Canadian Cancer Society is here to help. And we're here for everyone in 200 languages, including 14 Indigenous languages, and we're only a click or a phone call away. And as the only national charity that supports Canadians with all cancers in communities across the country, we're the voice of Canadians who care about cancer, and that's why I'm so pleased to speak with you today. Through our online and telephone services, we're hearing firsthand about the worries and anxieties. We're helping people, as well as their loved ones, navigate their new realities by addressing their concerns or separating the facts from all the fake news that's out there about COVID and cancer, and providing them with emotional support and resources to help them cope. And for a sense of what they're telling us, when the pandemic began, patients and caregivers were reaching out for information on COVID and specific information about the virus and cancer. And over time, these concerns have shifted to coping with feelings of isolation and depression, and now moving towards frustration and fear as their treatments are delayed indefinitely, and as people worry that this will affect their ultimate prognosis. Some tell us that they feel like collateral damage from the pandemic. Others say that they feel like they're on the Titanic and only those with COVID-19 are getting into the lifeboats. So how does the Canadian Cancer Society provide these services? Well, we fundraise almost $200 million a year through grassroots events, donations, sponsorships, online fundraising. We use that to fulfill our mission, which is to provide the support services that I've described, but also to fund life-saving research on all cancers. And we're the largest funder of cancer research outside of the Canadian government, and also to advocate for health policies to prevent cancer. As a result of the crisis, we estimate this large decline in our revenue and reductions in our research funding and our services. We're doing everything that we can to adjust and to adapt our fundraising and to stay connected to donors across the country. But as you make critical decisions about Canadian healthcare and emergency funding, we want to ensure that cancer patients and cancer charities are not forgotten. So I ask that you please consider what you have heard from, what you hear from the Health Charities Coalition of Canada and from Imagine Canada about the requests on behalf of our sector. And please consider the Canadian Cancer Society's submission to the Standing Committee targeted to address the needs of people with cancer and their caregivers, and specifically to provide funding to be able to continue our support services for the many Canadians living with cancer. We can help them cope with the pandemic now and help them cope through the backlog in the healthcare system that's going to impact their well-being for many months. And as we all get through this together, we're here to help. So thank you very much for taking a few moments to hear from me today.
Thank you. We'll go now to the Canadian Organization for Rare Disorders, Dr. Wong Rieger. Dr. Wong Rieger, please go ahead. 10 minutes.
Thank you very, very much, Mr. Chair and committee members. Thank you for the opportunity to be back before this committee on behalf of the Canadian Organization for Rare Disorders, Canada's national association of over 100 rare disease patient organizations, representing approximately 2.8 million Canadians affected by rare diseases, many of whom have underlying respiratory, cardiovascular, and immunosuppressive conditions that put them at high risk for COVID-19. First of all, I really would like to state that without reservation, that CORD joins with all Canadians in the fight against COVID-19 and strongly supports the federal, provincial, and territorial government actions to protect and treat all Canadians during this pandemic. We empathize with all of those who are suffering. No one knows more acutely than the rare disease community. First of all, the rare disease community knows the frustration of being unable to get an accurate diagnosis. In fact, it can take 7 years or more for a rare disease patient to get a diagnosis. We know the uncertainty of not knowing whether your condition will progress to a serious life-threatening stage. This is, in fact, a reality for many rare diseases, most of which have highly varied and uncharted disease progression pathways. Our community knows the urgent need to have better understanding of the disease. Sadly, many rare diseases cannot be traced to a single virus, but have multiple causative factors. Fourth, we know the despair of having no treatment or cure. In fact, only 5% of rare diseases have any effective therapies, and only a handful can be cured. And finally, we share in that desperate wish to prevent the disease. So CORD applauds the global multi-sectoral.
Excuse me, Dr. Wong Rieger, could you maybe hold your mic? Thank you.
Yeah, is that any better?
We'll see.
Okay, CORD applauds the global multi-sectoral collaborations that are coming together to combat COVID-19. Is that okay?
Yeah, just a little bit away so you're not directly speaking into the microphone. We get the pops and stuff if you do that, but close. What you're doing right now is probably perfect.
Okay. So we applaud the global multi-sectoral collaborations coming together to combat COVID-19, to treat, to find a cure, and to prevent future infections. We're especially heartened by the public-private partnerships, which are essential to getting to successful interventions as quickly as possible. However, in the same way that COVID-19 has exposed the inadequacies in Canada's healthcare system, the experiences of rare disease patients in this time of COVID puts in stark relief the lack of a comprehensive, integrated approach to rare diseases pre-COVID. So while each rare disease affects only a small number of individuals, there are more than 7,000 rare diseases that together affect 1 in 12 or nearly 3 million Canadians. Many of these conditions are associated with lifelong debilitating symptoms affecting not only the patients, but obviously those who care for them. So for Canadians with rare conditions, as you've heard for cancer and for lung disease, the fight against the disease doesn't stop during the pandemic. Indeed, in many cases, as you've already heard, it has become even more challenging. We have received numerous calls, requests, emails from patients trying to actually manage with their own disease during this time. In early April, we sent out a survey to our patient community to try to learn about the impact of this. We had about 300 responses in just a couple of days, and we were frankly shocked by the extent to which the lack of access to healthcare and other services is affecting them and the seriousness of the consequences. I'll just give you a snapshot. Half of the respondents said they had experienced difficulty receiving medical care, such as delayed or canceled surgeries, no blood work, limited access to dialysis, no physiotherapy. One patient said the surgery that's not happening would have resolved the problem. In the meantime, I'm not functional and I'm bedridden and in a lot of pain. Secondly, about 2/3 were concerned about seeking healthcare because of the fear of contracting COVID-19. One respondent said, I've been told, should I contract COVID-19, I would be low on the list for treatment due to shortage and a philosophy of survival of the fittest. Third, half said they could not access their rehabilitation or critical service, including personal support care. So I'm housebound, extreme mobility issues, nobody able to help because of fears and the stay home in effect. About 40% said they could not access the prescribed medications, not because of drug shortages, but because of logistical issues in the healthcare or pharmacy services or the lack of response to special access requests. In fact, in a separate survey to the pharmaceutical manufacturers, CORT did receive assurances that the Canadian drug supplies were not in jeopardy, that steps were being taken to meet future supply needs, and to even arrange alternative treatment sites if patients were getting infused. Furthermore, we were assured that ongoing clinical trials would not be interrupted, with adjustments made for alternative treatment sites, for monitoring and data collection if necessary. So in summary, it may seem self-evident that we should not neglect patients with serious chronic conditions while we battle a new disease, however rampant it is. Unfortunately, our survey and our calls into our info line paint a stark and disconcerting picture of limited, delayed, denied access to testing, to medical services, to surgeries, to rehabilitation therapy, to supportive care and medicines, all of which inevitably put patients' lives and their well-being at risk. The underlying problem we come back to is that Canada has never approved a rare disease strategy, despite having national strategies for cancer, diabetes, cardiovascular disease, and mental illness. Indeed, Canada is the only developed country in the world without an official national rare disease strategy. 5 years ago, in the House of Commons, CORT launched Canada's rare disease strategy, which we have put together, developed, endorsed by leaders from all sectors, and outlining 5 goals: improving diagnosis, providing for expert care and centers of excellence, assuring community support, including patient organizations, access to treatments, and support for research. Well, the strategy has yet to be endorsed nationally. It has nevertheless served as an important framework for a variety of important initiatives, including steps toward the development of provincial plans by Ontario and Quebec. However, it is clear that we cannot adequately and effectively address rare diseases through standalone provincial strategies and other piecemeal initiatives, any more than we could conquer COVID-19 if each province were working in isolation. Rare disease needs national commitment, resources, and leadership, particularly in this era of COVID-19. Of course, I would be remiss if I did not acknowledge that the rare disease community is very grateful to see in the 2019 federal budget the $1 billion funding commitment to develop a rare disease drug strategy. Ideally, this would dovetail with the supplemental process proposed by the Expensive Drugs for Rare Diseases Working Group of the provinces and territories. However, I have to reiterate that in order for a rare disease drug strategy to be effective, it has to be embedded in a comprehensive rare disease strategy. Moreover, I'm also compelled to point out that the greatest threat to the potential benefits of a national rare disease drug strategy is the Patent Medicine Prices Review Board regulatory changes that are scheduled for implementation on July 1st, 2020, despite the lack of broad stakeholder consultation. This will affect the rare disease community probably more than any others. To put it in context, the PMPRB changes, in particular, the application of the economic factors to set maximum drug prices, would put chronic disease patients, some chronic disease patients, at much greater risk than COVID-19. And ironically, if there were a breakthrough drug therapy for COVID-19, it would be unlikely to meet the new PMPRB pricing restrictions. We obviously don't believe the governments would reject a life-extending or life-saving drug for COVID-19 on the basis of the PMPRB economic factors. We simply do not understand why the government is seemingly allowing the PMPRB to deny access to life-saving and life-enhancing drugs for rare disease patients. I'll conclude with 2 key learnings that we have in requests. From our survey results, what we've identified, what we would like to have from the federal government. The first is that while you deal with the crisis, don't sacrifice those with other healthcare needs. Set up a parallel team to identify, prioritize, triage, and resolve the needs of those with chronic and other healthcare conditions. This extends obviously beyond the rare disease community, but it really does impact those with rare diseases disproportionately. The other big learning is that Canada needs an innovative pharmaceutical industry. Companies in Canada are stepping up to assure adequate supplies of emergency drugs and medical devices and are partnering with researchers to develop new tests, therapies, and vaccines for COVID-19. At the same time, they're ensuring that Canadians with rare and common conditions have continued access to the drug tests and other technologies that are needed. Perhaps this is truly the opportunity to develop effective public-private partnerships. The problems experienced by the rare disease patients and families were not directly caused by COVID-19. Sadly, it has taken a pandemic to bring the pervasive deficiencies and dysfunctions in our healthcare system to the surface. We urge governments to address those issues now. We in the patient community are ready and wanting to work with you along with our clinicians and our researchers. I would just add parenthetically that CORT has not applied for any of the support funds because we are, quite frankly, a very lean organization. We know how to work with limited resources. We have instead hoped that the funds would go to our 100+ patient groups, many of which are small, many of which are very much volunteer-led, rely on fundraising events, which obviously are not happening now. Thank you very much.
Thank you, Doctor. We go now to Healthcare Can. Mr. Cloutier, please go ahead. You have 10 minutes.
Merci beaucoup, Monsieur le Président.
Thank you very much, Mr. Speaker. Can you hear me?
Yes, I can hear you fine.
Okay. Healthcare Can is an organization that represents Canadian research hospitals, regional health authorities, and health organizations. So my thanks to the committee members for the opportunity to present to you today with my colleague, Dr. Brad Wooters of UHN, with whom I will split Healthcare Can's presentation time. Le milieu de la recherche, les
research environments, regional authorities, and research institutions in Canada have actively contributed to the responses brought to the COVID-19 pandemic.
Expose the gaps in the public health system and the healthcare system more broadly. One of those gaps is the fact that Canadian healthcare facilities designed for another time and place are among the oldest public infrastructure in use today, with approximately 48% of facilities being over 50 years old. And the picture in bigger cities is even worse, where 69% of healthcare institutions are over 50 years old. Nos hôpitaux font face à d'énormes...
Our hospitals are facing enormous budget constraints, and they are forced to postpone very important maintenance work that they need in providing quality health care to patients. We haven't funded adequately the maintenance of our health establishments.
We must complete the unfinished business of Medicare by closing the gaps in long-term care and our traditional institutions' healthcare system. As healthcare leaders now turn to addressing the backlog created by the huge numbers of cases and procedures delayed in the face of the pandemic, our focus must be on building surge capacity into our healthcare. This will require much more strategic support from the federal government as we work to address the coming surge of patients waiting for different types of care due to COVID-19. Mr. Speaker or Mr. Chair, another area of deep concern for Canada's healthcare organization is the very fragile state of Canada's health research enterprise. Much of Canada's health research talent is employed by research institutes based in healthcare facilities. That talent drives a $3 billion annual sector of our economy, employing nearly 60,000 highly skilled researchers staff nationwide. This not-for-profit sector accounts for the majority of their biomedical research that is conducted in Canada, including current essential research and clinical trials around COVID-19. Hospital-based research drives improvements in disease prevention, diagnosis, treatment, and care for Canadians. Two examples, Mr. Chair. Vancouver Coastal Health Research Institute has 9 major centers known internationally for their research excellence. It employs over 1,500 personnel engaged in research, 900 principal investigators, and graduate and postgraduate training conducting clinical and discovery sciences. Another example is the Research Institute of the McGill University Health Center is also world-renowned with over 1,200 graduate and postgraduate level trainees, 440 researchers and staff. It is recognized for groundbreaking work relating to health outcomes in transplantation, infectious disease, patient self-monitoring applications, among many others. That workforce is paid through a combination of public and private research grants, charitable donations, allotments from foundation, and contracts for clinical trials, which are almost all funded privately by biotech and pharmaceutical companies. That revenue base has all but evaporated in view of the COVID-19 pandemic. All research and clinical trials not related to COVID-19 have been either suspended or canceled, with severe implications for the sector's capacity to employ essential research staff and contribute crucial research improving Canadians' health outcomes. Les instituts de recherche en santé.
Health research institutions have welcomed the announcement of the emergency pay grant, and they excusez monsieur, but sorry, just un instant.
Pardon me, Mr. Cloutier.
To some form of federal support. Federal government can avoid those layoffs by granting research institute based in healthcare organization access to the Canada Emergency Wage Subsidy on the same terms and conditions as other industries. This is why we are urging the government to do this today and to treat us equally. This could be done by a simple change of regulations, a minor change that would give Canada's health researchers the security they need to weather the storm of the present crisis. Now I'll pass it on to my colleague, Dr. Brad Wooters, to say a few words from his perspective.
Thank you, and thank you.
Actually, before we do that, just let me remind everyone that it really helps with translation if when you speak French, you go on the French channel. When you speak English, go on the English channel. I know it's kind of awkward when you have both languages integrated into your speech, but otherwise, the sound levels on the translation come through at the same level as the floor, and it's very hard to hear. So thank you very much. Please go ahead, Dr. Wooters.
Thank you, and thank you for the opportunity to speak today. As Paul Emile mentioned, on March 15th, nearly all hospital-based non-COVID related research across Canada was suspended. At that time, our organization had budgeted $460 million for our hospital's research operations for the fiscal year, a sum that employs 1,000 scientists and 4,000 other highly skilled research staff, including clinical research associates, research nurses, laboratory technicians, biostatisticians, data managers, graduate students, and postdoctoral fellows. Our organization is the largest research hospital in Canada and is one of the top centers in the world. It includes the Princess Margaret Cancer Centre, ranked as in the top 5 cancer centers in the world. And it also includes the Toronto General Hospital, ranked this year by Newsweek as the 4th best hospital in the entire world. We perform more organ transplants than any hospital in North America and have over a century of research accomplishments that include the development and application of insulin to treat diabetes and the discovery of stem cells. But never in our history has our research future been more at risk than it is today. The majority of our industry revenue has been lost because the clinical trials and research projects they support have been suspended. Charities, as you've heard today, have also begun to cut their giving, resulting in forecasted losses of revenue for our institution alone of more than $10 million per month. We have managed to stretch our resources for the past 7 weeks without job action and layoffs in hopes that the federal government would provide us access to support programs like the Canada Emergency Wage Subsidy. We operate in an extremely competitive environment with other health academic medical centers around the world. and has been important for us to keep our staff engaged, part of our institute, and ready to relaunch and compete for funds when we come back. Many of our researchers and scientists have also jumped in and contributed to a rapid response to COVID-19, bringing their unique skills and talents to the treatment and prevention of this disease. We have launched new clinical trials in patients. We are exploring the fundamental biology of the virus, and we are developing new vaccines and therapies. However, 80% of our staff remain unable to continue essential research into cancer, into lung disease, into cardiovascular disease, Alzheimer's disease, rare diseases, diabetes, and many other key diseases that kill the majority of Canadians. Since our suspension, we have had numerous contacts with officials in several government departments. All of whom have been extremely responsive and understanding of the situation that we are in. We have asked to have the same opportunities as other businesses and not-for-profits, but have been excluded from these key programs because we are located inside a public hospital. On May 1st, we were forced to begin the process to identify roughly 1,500 staff for a first round of job layoffs because of the suspension-induced loss of revenue. If we continue to be unable to access these federal supports, we will face large in-year operating deficits, additional layoffs, and insufficient revenues to support our costs. Honorable members, institutions like mine all across the country are currently ineligible for the wage subsidy based largely on a technicality. Because these health research institutes are physically based in public hospitals, they are designated as public institutions and excluded from eligibility. Our hospital and the care of patients is funded by the Provincial Ministry of Health. However, we are legislatively prohibited from using any of that provincial support for our research. Instead, our research is funded by a wide mix of over 900 different organizations. For the most part, we are not funded out of public sources. And to the extent that those funds do come from public sources through competitive research or innovation grants, these have also stalled since March. I would also mention that eligibility to these programs would come at a marginal cost to the government. The staff, if we are forced to lay off, will have access to the Canadian Emergency Response Benefit. But it is clear that it would be much more effective to keep those employees part of our organization. If we are forced to lay off that staff, they will be unproductive, they will be unable to contribute to COVID-19 research, and we will be at risk of losing them. This jeopardizes our ability to restart research and to compete for international industry and other funding when we come back. Without urgent support from the federal government, we run the risk of setting back health research in Canada by decades and undermining patient outcomes in Canada in the future. Thank you.
Thank you. We go now to the Heart and Stroke Foundation. Ms. Simard, please go ahead, 10 minutes. Pardon me, Ms. Simard, you're muted. You're muted. Go ahead. Please unmute and start over, please.
Sorry about that. Thank you very much, Mr. Chair and committee members, my co-witnesses.
Actually, you're very weak.
En anglais, mais je suis disponible pour...
Comments will be in English, but I'm ready to answer your questions in French and English.
Our organization, the Heart and Stroke, there's a lot of echoes with what other witnesses have said. And really what I'm going to talk about in my testimony is to highlight for you the impacts of COVID-19 on those with heart disease and stroke, their caregivers, how we have been responding and supporting them through this time, but also the financial toll that the pandemic has brought on us within this sector, and also to echo some other comments, specifically the issues regarding health research at a time when science and research are incredibly important. So if I first focus on COVID and the intersection and our understanding, we know that it has worse impacts on people with underlying conditions, such as heart disease and stroke. We know that people with heart conditions are 4 times more likely to die, if they have the virus than those with no underlying conditions, and those with previous strokes are 3 times more likely to die. And as some of my other witnesses spoke about, we know that it has devastating respiratory impacts, but underlying and emerging evidence is showing that it actually has a significant involvement with the cardiovascular system and serious consequences like clotting, stroke, cardiac arrest, heart attack. And right now, like others have talked about, people with our conditions and risk factors are very much adhering to the physical distancing and self-isolation precautions. But what is really happening, and a worrisome, very unintended consequence of the pandemic, is that people experiencing signs and symptoms are not seeking medical attention for fear of coming into contact with the virus, or justifiably worried about overwhelming our health system. And we at Heart and Stroke have just done a piece of data analysis with the Canadian Cardiovascular Society, and we found that in Ontario, there's been a 30% reduction in ER visits over the period of March and early April for STEMIs, which are the most serious type of heart attack, a similar reduction for stroke-related visits. And in Vancouver, at the Vancouver Coastal Health, they're seeing a 40% reduction in STEMIs. So we're very quickly mobilizing, continue to draw attention not only to COVID, but to the importance of really treating medical emergencies as such, to seeking care, and very much echoing what some of my other colleague witnesses spoke about. People with heart disease and stroke are managing complex chronic conditions with a lot of medications, rehabilitation, and a lot of them now are not getting those kinds of support and care that they need, in addition to things like delayed surgeries, delayed treatments. In fact, for us at Heart and Stroke, it's been a bit of an overwhelm of people seeking guidance and support. In the last 2 months, we've had 1 million people coming to our website and nearly 100,000 accessing our COVID-specific resources, webinars, supports.
Pardon me, Ms. Smart. Could you hold your mic a little bit closer to your mouth, please?
Certainly. Is that better, Mr.
Much
Chair?
better. Absolutely.
Thank you. I beg your pardon. So we have also, at Heart and Stroke, we actually produce the best practice guidelines for stroke, and we have adapted those as well to work with how clinicians and institutions can treat stroke in this very challenging time. But one of the realities is, despite all the quick action during COVID, we know that there's going to be very significant lasting impacts. And for organizations such as ours, quite a reduced capacity to provide the kind of support that we have always provided. Like other health charities, we have had significant impacts of the pandemic. We have all of our fundraising activities, except online, are largely on hold. We have had already an immediate revenue loss of $25 million, and have accordingly made many difficult decisions, including laying off nearly half of our staff. But at the same time, we recognize that heart disease and stroke affects nearly 1.6 million people every year. So really, we need to still be focused on the going forward. Within all of the things that we talk about in terms of information and support and working with the healthcare community, the other piece that we also do is, we are the second largest after the federal government funder of cardiovascular disease, and we support some 700 researchers across the country, and our funding to them is quite precarious. I think the challenge that we're all quite concerned is health charities like ours, we've delayed or canceled our competitions. We're really wondering about delaying payments, but as COVID does create some research opportunities, and many researchers, tremendous innovation. There's also hundreds of other research projects, years of money invested, millions of dollars that are sort of nearing completion and now in danger of being wasted if we can't continue. And I think, for all of the partnership between health charities that are more public and vocal and talking about the change that needs to happen, working closely with research institutions, researchers, scientists, clinicians, really translating that science into action. That partnership is a very, very successful one, but one that is at risk. And if we can't continue, not only is that knowledge translation at risk, but the erosion of expertise, all the lost progress on experiments and clinical trials. It's a very beautiful thing when it works, and really a complementary piece that is so fundamental to caring for the many people with chronic disease in Canada. So our focus and our appreciation of being able to speak with you today is first to speak to the partnership among health charities. We've heard reference to the Imagine Canada partnership and the health charities of Coalition of Canada that are asking for broad support to non-for-profit and charities operating cost. If we just focus on the research component of the health, we fund about $155 million worth of health research every year, and are in a period where we're really wondering if we're going to be able to continue to do so. So a way that we could kind of come forward and sustain that decades-long, century-long partnership, if you're the Lung Association, we're a mere 70 years old, is really about trying to be able to sustain our ability to be part of that research and then to translate that research into impacts for patients. The two other small points I would suggest is the federal government has made huge investments, 1.1 billion in COVID. I think for really one of the questions is how much of that will actually look at the intersection between underlying medical conditions, compromised and vulnerable people, and what those outcomes are. I think there's a real sense that it will be much worse for them, and we know that already. And then the last point is we have, as health charities for a long time, had many partnerships, including with the federal government. And one of the ideas is we're very open to solutions for maybe we could do a partnered model by which we could match donor dollars with federal dollars, public dollars, to sustain some of those research investments. At Heart and Stroke, we've been very grateful to the federal government for a 5-year, $5 million research on women's heart and brain health that we matched donor dollars to federal dollars to really push women's health equity. So I think in closing, I would just echo not only my comments, but the comments of other witnesses. This is a precarious time for health charities like other organizations, but the intersection between the patient experience, the caregiver experience, health research, and the translation of that into awareness and information and action is really a unique place that the health charities play. And we thank you for your consideration and attention to our requests.
Okay, thank you everyone for your presentations. We start our rounds of questions at this point. We will have 3 rounds of questions. We will start round 1 with Dr. Kitchen. Dr. Kitchen, please go ahead. You have 6 minutes.
Thank you, Mr. Chair, and thank you everybody for your presentations, and it's greatly appreciated to hear from you. Definitely we have heard across this country how COVID-19 has consumed everything, and other diseases, other illnesses have been totally forgotten about. And as we've heard, where we see patients that are not seeking care from hospitals or not seeking care from their doctors when they're presenting with signs and symptoms because of their fear that they might contract COVID-19 in some manner at all. Dr. Wooters, and I just want to comment. I want to thank you for your statement when you talked about the exclusion of you for your researchers and the issue of the wage subsidies program, because that's something we've been trying to point out when this was brought out. There were a number of issues that were missed, in particular, small businesses that were sole practitioners, et cetera. And this is another one that definitely we need to be focusing on, because our health research is paramount for this country to progress and for the safety of all Canadians. So I thank you for your comment on that, and look forward to, we will bring that forward. At least I will anyway.
Thank you.
This committee has heard time and again that PHAC was not adequately prepared to deal with the spread of COVID-19 in an efficient way, and in part due to the underfunding and mismanagement of healthcare preparedness. In fact, just yesterday, we heard from the Canadian manufacturers and exporters who had a plan put forward in 2009 after the SARS epidemic and in dealing with an influenza pandemic program. And basically what they said to us yesterday was, we forgot about it. Governments forgot about it. And that seems to be happened when PHAC actually started in 2003 to develop these things, and it seems to have been forgotten about. Now, Mr. Cloutier, in a recent article in the Hill Times, you said, and you indicated that, and you said a couple of things that strike me. One was that given Canada's experience with SARS, Canada should not have experienced the critical shortage of medical supply in its healthcare system. Now, further in that interview, you said PHAC's visibility and access to cabinet should be increased, even outside a disease outbreak, through the establishment of a pandemic preparedness council. Given that PHAC was established as a result of the SARS epidemic, and given that we have seen significant gaps in preparedness by PHAC, what would a pandemic preparedness council do differently to address the shortcomings in Canada's COVID-19 responses? I'm wondering if you could comment on that, please. I'd appreciate it. Sorry, you're on mute, sir.
Thank you very much for that question, because it is a very important question. And I certainly would hope that, as I said in my article, that SARS was really a wake-up call, and I think that now COVID-19 is now seen as a clarion call. I think what you have to look at is the power that's given to the Public Health Agency. And when I use the word council, I pointed out that it would be important for that person who's head of the Public Health Agency to have access to cabinet and to present his or her views as to what is the state of our nation in terms of pandemic. At this moment, I feel that it's a bit too bureaucratic. It is reporting to a number of people, when in fact we know that in Ottawa, the decisions are really made at cabinet. And I use the word council, hoping that in this situation, and it's only in this situation because of the model that we would have, that this person could actually be reporting to the Deputy Prime Minister through a committee that would be established at cabinet to discuss pandemic, any major challenge that would be coming up, rather than just staying in their offices and looking at what is being done. The other thing too is the sharing of information, and also delegating the powers that they should have between provinces and Ottawa, in my view, needs to be worked at and needs to be reviewed as we go forward. So I don't know if I've answered your question.
I appreciate that. I was interested. It was something that caught my eye, and I wanted to, because you were here, it gave me an opportunity to ask that question. A little bit further in that article, there was talk about the funding for PHAC, and it has decreased over the past few years, with its budget declining by 7% in the fourth quarter of 2019. That equates to about $47 million being cut. I'm wondering what reforms need to be taken at the federal level with respect to ensuring the sustained and adequate funding of PHAC, especially in terms of preparedness. Where did some of the gaps lie? Can you identify that?
Well, some of the gaps, for example, if you recall a few years back, we did have a Minister of State for Public Health. We no longer have a Minister of State for Public Health. We also had at one point where the level of delegation, the level of authority that that person would have in reporting authority was much higher than it is at this moment. I believe that if you really are serious about public health in Canada, you need to give them the tools. It can't be just a toolbox that's not open and not used. And I believe that it's important that that person or the agency has the authority, not only in Ottawa, but also has the authority to conduct research and analysis across the country. There are situations where when you look at the PPEs and you look at the stockpile and you look at ventilators, these are things that should have been managed in a much better way. And I think this is where the Public Health Agency, if it had granted the authority, it probably could have done a better job.
Thank you, Dr. Kitchen. We go now to Ms. Sidhu. Ms. Sidhu, please go ahead. You have 6 minutes.
Thank you, Chair. Thank you all the witnesses to being part of us. On Sunday, I hosted a teleconference with the senior in my riding, and the major concern I heard from them was the pharmacy dispensing fee. Given that we need to ensure all Canadians have access to their medications to get it, when restrictions came into play, there were changes in the frequency of prescription refills. Those who used to have 3 months dispensed were restricted to only 1 month at a time. That also tripling the overall cost of the dispensing fee. I would like to hear from the group heart and stroke or rare diseases. What is your thought on it, and how it is impacting on Canadians? Rare diseases, they can answer that. You're on mute,
Sorry,
Dr.
yes. I was trying to do it under my picture. I realized that was the wrong spot. Thank you very much. We also heard many concerns around dispensing fees. And again, as you said, could only get a small supply of the medicines, could not get it from your normal pharmacy. So when you went to another pharmacy, there was huge issues, especially for some of the rare disease patients where the medicines they're getting are not routinely listed in terms of dispensaries. We also had a lot of problems with people who, because of COVID and because of the impact on them, they were actually have to use more of their medications during that time of infection and could not get an understanding from the pharmacy that they actually, what you were giving them was not a 30-day supply, it was now a 10-day supply. So this was a huge issue.
Pardon me, Ms. Wong, or Dr. Wong Ryder, Reger, would you please hold your mic a little further?
Sorry about that, I forgot. Yes.
No.
Yeah, so we heard a lot of those same concerns that, and again, as I said, we had 50% of the people said I could not get my regular, medications. And almost every case, it had nothing to do with not having the drugs there, though in some cases it was. And it was actually the more routine medicines that were not there, amoxicillin. In some cases, we had a number of patients that reported that they couldn't get access to, interesting enough, chloroquine, that this was something they use normally. And in several cases, we're told we're holding on to the supply because we want to save it for COVID patients.
So do you think the recent investment of the $240 million our government has made to the provinces and territories for virtual care will ease this issue? Do you have advice on these Canadians? Can you share any other group if they want to? So
I could just speak briefly to it. I think among the top concerns that we hear from cancer patients, it relates to financial strain overall. That when you have a chronic health condition like cancer and others, that there are burdens placed on patients depending on where they live, what kind of access they can to healthcare they have, and the financial strain that it places on people from having to get to treatments, losing employment. Any of these changes that add to financial stress are the kinds of things that we hear about and that patients feel very deeply.
The other piece that if I may add, in terms of virtual care, what has actually been a success story is how so many, not only healthcare providers, clinics, but patients have responded to virtual appointments and, renewing prescriptions by email and getting consent by video conference. So there is a lesson in here that is a success story, that is about how for so long, there's been a fair bit of resistance and challenges. There's been a bit of a breakthrough in this period around accessing different modes of care and an acceptance that wasn't there. I'm not diminishing the challenges presented, but there is a piece about the virtual appointments, telemedicine, and the adaptiveness that both patients, caregivers, and healthcare providers have shown that I think is an important go forward strategically for the health system.
I'm just going to maybe add to that just for 2 seconds, Mr. Chair. I would sort of echo those comments. In Alberta, we've been using telemedicine for a long time for rural and remote communities, and it's worked very effectively. And to sort of see it gravitate into the more urban centers has been real positive. So I think the investment into virtual care is good for now, but it's also going to be helpful for the future as well.
I don't mean to take up all of your time.
Ms. Wong-Weiger, your microphone.
Oh, sorry about that. I don't mean to take up all of your question time, but I have to put in a very strong word about rare diseases. For our patients, because they don't normally have a good plan of care, their specialists are oftentimes far isolated. We have patients that say, I can get a meeting with my family physician, but they know nothing about my disease. So we come back to needing to have comprehensive plans of care for patients with rare diseases that they can own, that they can hold. This is what many other countries do. We need to be able to have the ability for patients to be able to manage their care, and then they can actually have access to what we hear is happening in cardiovascular disease, in cancers, in other conditions. So for us, this is something that's actually turned into a nightmare for most patients because they can't get access to others that would actually know anything about their disease.
Thank you, Ms. Sidhu. I would point out to Mr. Cloutier that when you're answering a question, if you could leave your headset on so we can talk to you if there's translation issues or sound issues and so forth. Thank you. Dr. Wong-Weiger, certainly try to remember your microphone, okay? We're going now to Mr. Theriault. Mr. Theriault, you have 6 minutes. Please go ahead.
Merci, Monsieur.
Thank you, Mr. Chair. Thank you for all the witnesses for their testimonies. Madame Seal, there were experts who came to tell us that it wouldn't be the only pandemic that we would be facing in the coming years. I read your brief with great attention. It is quite detailed. Other witnesses also came to tell us that the underfunding of the healthcare system made them more precarious, more fragile. So when faced with a pandemic as severe as this one, as virulent, as awful as the COVID-19, obviously the system collapses and is not able to take care of its patients. The system was already under extreme tension, and for diagnostics, we know how important it is to get an early diagnosis when you have a cancer. The first cause of mortality is cancer. Of course, in your brief, we can see that patients and caretakers and families feel that they are left aside. It's like we haven't learned from SARS. It's clear in your brief you're saying that maybe this time we should be able to foresee the long-term effects of this pandemic and what impact it has had on our patients' treatments. And we didn't gather all this information during the SARS episode. If I'm looking at what you're doing, I was thinking that you would be an important, interesting, a relevant organization to be at the head of this type of research? What would you think if we invested the necessary money for you to head this type of research project? Would you not be the best position to make this follow-up that hasn't been done during SARS?
Sorry, I missed the very beginning of your comments, but I think I caught the rest that was directed to me. Is that correct?
Oui, absolument.
Okay.
Yes, absolutely, indeed.
Yes, thank you. Absolutely. I think there's going to be many lessons to be learned. And from the patient perspective, I think there has been a great deal of understanding that the healthcare system is in an impossible situation and that we've had to prepare for the worst, which at the beginning of the pandemic really looks like, when you look around the world, that of course Canada needed to avoid the worst that we saw in other countries, and perhaps our preparation has meant that we won't see that in Canada, which I think cancer patients, like all of us, would be very grateful for. But absolutely, there are lessons to be learned here about the impact. One of the things that's a great challenge of our Canadian healthcare, and that applies in cancer very specifically, is that the lack of access to data about patient experience that is held in different pockets across the whole country makes it quite difficult to in real time understand what people are going through and then adjust. So I think there's great lessons to be learned. There's absolutely research that should be done to understand how we would not just deal with another pandemic, but also just create a health system that can be more responsive to people's needs on a very timely basis. And yeah, we would think that would be another good outcome from what's been such a challenging situation. Just as Ms. Simard mentioned about virtual care being something that's been a real positive leap forward that the pandemic has caused, and I think we could apply the same to understanding the impact of strain on the system on different types of diseases and patient groups.
Merci. Vous avez parlé.
Thank you. You want to add something, Mr. Cloutier? We can't hear you. You're on mute. Yes, Mr. Thériault, your question is very relevant. I wanted to bring something else to it, though. Not contradict what you said, but just to add something. Today in Canada, most of our hospitals are working beyond the capacity which should be the standard in a hospital. Our hospitals are working at 120% of their capacity. There's not enough beds. There's not enough space for patients. So imagine with COVID-19, the stress that was put on the system, which is already at overcapacity. With COVID-19, people going to the hospitals were forced to let go some patients, to let them go home, to transform intensive care or switch them to the operations, the surgery section. This is caused by a lack of adequate infrastructure. They don't have what they need to respond to what they need in Canada as it is.
Thank you, Mr. Thériault. We go now to Mr. Davies. Mr. Davies, please go ahead. 6 minutes.
Thank you, Mr. Chair, and thank you to all the witnesses for being here. My first question is to Ms. Seal. Ms. Seal, you've talked about the profound impact on your finances of the Canadian Cancer Society, and I know that you've requested emergency funding of $16.4 million from the federal government for a few things to protect vital services, reduce isolation, support mental health, and expand navigation resources, and to provide practical supports for cancer patients. Has the federal government responded to that funding request yet?
Thank you. We've had numerous positive conversations about the request, and I think a great deal of understanding of the needs of cancer patients and the role that we could play in supporting them. But those conversations are still ongoing, and we haven't had any confirmation of funding.
Okay, thank you. Mr. Cloutier, you talked about give some pretty sobering statistics about the age of hospital infrastructure in this Canada, and apparently the majority of it is well over 50 years of age. You've also written that Canadian hospitals are forced to defer much needed maintenance due to budget constraints in order to maintain frontline care for patients. And you've noted that we have not kept up adequately funded the upkeep of our health institutions. In your view, what does the effect of this deferral of needed maintenance have on infection control in our hospitals?
Well, it certainly has an impact, and especially an impact on patients who are either vulnerable or older. It also has an impact on our ability to introduce new technologies within our hospital sector. I'm always reminded that one of the hospitals to which I visited was receiving a gamma knife, but the infrastructure in receiving the gamma knife did not allow the gamma knife to be placed within that hospital. So it has an all-around impact on the organization. We had estimated a few years back the amount of projects, and we had gone to many of our institutions who are a member of Healthcare Can and asked them what projects would they put in place to allow them to really upgrade their institution. And I believe that number is in the billions of dollars. I don't have the exact number. And this leads me to my last point on this thing is at this moment, hospitals are not allowed to access any infrastructure funds. And again, it's a simple regulation that says that does not allow hospitals and schools or universities to apply for the competition within the infrastructure fund envelope that the government has. Mm-hmm. I believe that that's unfair. And I believe that hospitals...
Mr. Cloutier, could you hold your mic a little higher, please?
It doesn't work.
Okay.
Thank you, Mr. Cloutier. I'll move on to another question. You've also written that once COVID-19 is behind us, it is imperative that we complete the unfinished business of Medicare by closing the gaps in long-term care and traditional institutional healthcare systems. There's been some talk lately about establishing national standards for long-term care, perhaps bringing under the Canada Health Act or establishing a federal transfer to the provinces and territories, but tying that money to observing higher standards of care for long-term care for seniors. Is that something that your organization would endorse?
Yes, it would be something to which our organization would endorse, because I find that the long-term care organizations have been really left behind. They should be enshrined in the Canada Health Act. I think that would be a first step. They need to be a partner in the delivering of healthcare. They can't just be put on the side and thinking that they will organize by themselves. I mean, we saw the complexity with the COVID-19 between what was happening between hospitals, long-term care, and the delivery of the care. So to me, it would be an appropriate move, and I think a political move that would be welcomed by all Canadians.
Thank you. Dr. Wouters, I just want to make sure I understand this. You're saying that non-COVID-19 research in Canada is not being funded right now purely because the CERB criteria that have been set by the federal government exclude hospital or clinical-based research. Is that correct? Do I understand that correctly?
Yeah, well, the main issue around the reduction in revenue is because when research is suspended, it means that much of our revenue also gets suspended. So we do a large amount of clinical research that's funded by external industry, clinical trials, pharmaceutical companies, biotech companies. And because what the hospitals have done to prepare for COVID-19, and as you heard from the other witnesses, a large number of those clinical trials have been stopped, and that revenue has also been stopped. For us alone, just our single institution, that represents a drop in over $6 million per month in revenue.
And the remedy for that, is what? What advice would you give us to recommend to the government to fix that?
Yeah, well, the remedy is, that supports at our institution 700 people, and access to the wage subsidy program for those 700 people would allow us to keep them employed and bridge through this suspension so that they can participate in COVID-related research, and they can be there and ready for us to come back when research gets turned on, and we can go out and compete for those dollars again. It's a very competitive environment. There are health, hospitals all over the world that compete for those funds for those clinical trials. We want Canadians to have access to those trials, but it means we need, very strong clinical research and clinical scientists here that are able and ready to carry out those trials.
Thank you, Mr. Davies.
Thank you.
We go now. That brings round one to the close. We'll start round two at this point with Mr. Weber. Mr. Weber, please go ahead. 5 minutes.
Okay, well, thank you, Mr. Chair. I will continue on with Dr. Wooters just on that specific topic of the suspension of research. Is it occurring throughout the world? Other countries, have they suspended their research as well in these areas?
They largely have. Every academic health science center, like those in Canada, have largely been suspended. Whether this is Harvard or Stanford or Johns Hopkins in the United States, anywhere in Europe, they're all in very much that same situation. Okay. How they all respond is a little bit different because they're in different jurisdictions.
Okay, thank you. Question to Dr. Bhutani. Dr. Bhutani, have we seen any evidence at all of permanent or long-term lung damage in those who have contracted the COVID-19?
So thanks for your question. And so currently, the evidence is building in regards to what the long-term effects actually are going to be. And there's going to be a multi-tiered probably response or expectation of that. If they've had mild symptoms, probably at the end of the day, probably not a lot of damage, but the patients that get admitted to hospital and then ultimately go to intensive care units and be put on ventilators, there's a potential for them to develop some long-term consequences. We are currently in Canada and around the world trying to follow these patients in clinics carefully after they get discharged from hospital and seeing what the natural history of the progression of this disease is going to be. So once they get discharged from hospital, they'll have a lung specialist, at least our institution, that will follow them up longitudinally, taking a look at their lung function over time. So the question is uncertain at this point in time, but I think the length of stay in the ICU, the type of care they get in the ICU, and types of complications they develop in the ICU will all impact the kind of expectations that we have.
Right. And that potential damage, is it directed because of the actual COVID disease, or is the ventilator the issue there?
Yes, that's a great question. I give a lecture to medical students on this every year, so if you have an hour, I can take you through all of it. But the reality of it is that there's going to be the acute problem and then the chronic problem. So the infection itself, what it does is it results in a massive inflammation within the lungs, and the lungs harbor a lot of inflammatory cells. And so if that inflammation becomes, in the short term, becomes very severe, it can lead to permanent damage to the lungs. So the infection itself can lead to that problem. It can be complicated with what we call sort of ventilator-associated complications. So when the lungs get inflamed like that, they become very stiff. The lungs are normally very pliable. They're like a balloon, inflate and deflate very easily. But when that inflammation sets in, they become very stiff. And so when you're trying to drive air into this stiff bag, what's the chances of developing complication like a collapse of the lung or a puncture of the lung can happen. So those are ventilator-associated complications. Those are very well studied, and there's strategies within the ICU to prevent the frequency or the occurrence of it. But at the end of the day, there's still that potential risk of ventilator-associated complications.
Interesting. Staying with you, Dr. Bhutani, you talked a bit about some medicines that should not be prescribed during this pandemic. So are you aware of patients that are actually being denied prescriptions because of the COVID and denied prescriptions on their conditions other than their COVID conditions. Am I making sense there?
Yeah, no, 100%. No, absolutely. Yeah. So in the pulmonary, the lung world, we use for both the sort of two primary conditions are asthma and chronic obstructive pulmonary disease. For both of those diseases, we use medicine, sort of the broad term is inhaled corticosteroids. So it's a very, very minute dose of steroids introduced into the lungs to help deal with the condition itself. The concern that patients and other practitioners have had is that steroids do suppress your immune system. And so if you have asthma or you have COPD, if you're taking this inhaled steroid, would it put you at any higher risk of potentially acquiring that infection? And so there's no evidence to suggest that that is the case. And in fact, it's the opposite, that we really want patients with those two conditions to optimally manage their lungs or their lung condition to prevent them from developing maybe some of the more serious complications of the infection if they were to acquire it. So in fact, we tell them to be more compliant with it. The only issue that we've run into in terms of dispensation is because of the pandemic and the preparation for a potential hospital surge. The Health Canada had recognized through a report from the pharmaceutical industry that salbutamol, which is a rescue inhaler, also known as Ventolin, you might recognize it as being kind of the blue inhaler. That's the one that's kind of most commonly seen around. So that Ventolin, which is really to be used in a rescue circumstance, there's going to be a potential shortage of it because hospitals had acquired a large quantity of it in anticipation of a hospital surge. And so Health Canada and the partners that we identified in our note got together and developed a strategy. And so the comment earlier about the 1 month dispensation really from our world has come from that standpoint, because we weren't sure as to what was going to end up being the need and the requirement as the industries try to replenish their supplies. So right now, no concern. I think we've developed a really nice mitigation strategy to deal with that should that happen.
Thank you, Mr. Weber. We go now to Mr. Van Bynen. Mr. Van Bynen, please go ahead, 5 minutes.
Thank you, Mr. Chair. And I also want to thank the witnesses today. You're bringing a lot of important information forward for us. My wife volunteers at a cancer center at South Lake Regional Health Center, but since the outbreak of COVID-19, she hasn't been able to do so. And I know that the work of volunteers is important to the patients, their families, and the centers. So I'm wondering, Mr. Cloutier, if you could share how the centers who rely on the help of volunteers are coping in their absence during COVID-19.
Mr. Cloutier, you're muted, and please speak loudly when you do speak. Your sound apparently is not very good.
Okay. I think they're managing it with a lot of challenges and difficulty. I think they're trying to get help by other healthcare providers within their own community. I know for a fact that within hospitals, staff that were assigned to a particular floor were reassigned to another position within the COVID-19 area. So there is some flexibility, but sometimes it's very difficult. And I'll give you a small little example. I'm a resident from Ottawa, and I try to offer my help at the Ottawa General because of my work. I believe that we are a challenge. You have to be careful as to how many people you bring into the system, because if you do, there's higher risk that you may be then an individual that will have the virus. So there's a lot that has to be done in terms of managing the situation in the system. But I would certainly encourage your wife to continue to offer her service, maybe to an area where it's less risky for her own life.
Great, thank you. Now, the idea of greater pan-Canada collaboration has been a recurring topic of conversation throughout these committee meetings. And I'm wondering if the organizations and the hospitals that Health Care Canada represents across Canada have been collaborating during the pandemic, and specifically, what is the process for identifying existing health resources and gaps in health equipment and resources in hospitals, and how is this information being communicated at the federal, the regional, and the provincial levels? And in your view, how could communications between hospitals and different levels of government be improved such that the provincial, the federal governments have a better understanding of the needs of the healthcare provider organizations?
Thank you for the
Do you
question.
want any parts of that repeated? Yeah.
No, I think I have it, but if I do get lost, please help me.
Thank you.
Within each of the provinces, there's a lot of communications and meetings that are happening between these various hospitals to discuss PPEs, ventilators, and how best to deal with some of the patients that have come through the hospital. That's done at the provincial level, and it's very similar to the other provinces. They do the same, and then they report usually their findings to the government, to their Ministry of Health. Where I think there was a lack or where there was a gap, ou en français, une lacune, it was at the federal and the provincial level, where sometimes I felt that the federal government did not have the appropriate information to actually assess and then follow that by making a decision. But I think within the province, within the regions, or at least those members of our organization, were in constant conversation with their neighbors to discuss issues, practice, lack of ventilators, and see where they could actually get some PPEs and ventilators. The conversation was also done on a frequent basis at the provincial level, that I know that for a fact. And sometimes even some of our major hospitals would have conversations at the international level only to be able to have access to additional PPEs and ventilators. So that is done at the provincial level. I think we have to strengthen the coordination and the information from the provinces to the federal government and federal government to the provinces. That's what I would suggest.
Thank you, Mr. Van Bynen. We go now to Ms. Jansen. Ms. Jansen, please go ahead. 5 minutes.
Yes, thank you. Sorry, I was just unmuting myself. I'd like to start my first question and direct it to Healthcare Canada, to Dr. Wouters. So just for clarification's sake, your organization represents health researchers across Canada, correct?
Well, Healthcare Can represents health researchers across Canada, research hospitals across Canada. We're one of those.
Okay,
there
great.
are more than 40 such organizations, yeah.
Okay, excellent. So you mentioned the fact that all research and clinical trials in Canada that are not related to COVID-19 have been suspended or canceled. And that I understand if trends hold, the pandemic will cripple Canada's overall research capacity. So in light of this information, what do your Canadian or the Canadian research members think of the $850 million research grant announcement made by the Prime Minister on Monday, of which $840 million will go to the WHO, according to a tweet by WHO Director General Tedros?
Well, I think the investment in COVID research is welcome. This is clearly a huge worldwide pandemic that needs to be solved, and I firmly believe that science and research is going to be our path out of the pandemic. Okay. And so the investment is good. But it's a piece of it. And I think, what we're here today and what we're talking about today is that the larger research infrastructure, what we're hearing from all the charities and the other parts of the research investment has not been addressed and is in a very fragile moment.
Yeah, so that money could have possibly been better used here in Canada is what I was hoping you would say, but maybe not. I'm going to now move my questions on to Mr. Terry Dean from the Lung Association. I've been hearing that there are some pressure on doctors to put COVID-19 down as cause of death when comorbidity issues are much more the reason for a patient's death. I'll just give you an example. My grandfather had COPD, but he died of pneumonia. My dad, same, had COPD, also died of pneumonia. Do we have any idea how many deaths currently attributed to COVID-19 should more likely be attributed to comorbidity issues?
Thank you for the question. At this point, I'm not aware of the specific answer, other than to say we know many of these patients are older. They suffer from many different diseases, many different comorbidities. So to be able to specify that specifically COVID-19, I think would be very difficult. We spoke earlier of some of the surveillance that's needed in Canada to help us understand what's happening. And I think this is a great example of work that data can inform the decisions we want to make down the road. And I think an investment in that particular area should be something the government's considering.
Okay, so you think that if we had the right kind of investigative technology, we'd be eventually able to sort through those questions?
The hope is that information will help us make better decisions. Right now, I don't think we have a solid enough base to be able to make that specific confirmation.
Thank you. And then my last question is for Dr. Juan Riegers. I really appreciated the information from your survey results stating that many non-COVID patients are having a hard time accessing healthcare right now. I had heard of a farmer in Ontario who had a staph infection. He'd called the hospital to ask if he could come in because he wasn't feeling well. And they told him no, call Ontario Telehealth. He didn't receive a call back right away and was eventually found dead in his home. Now, I know that in BC here, they'll be studying causes of excess deaths that were not directly blamed on coronavirus, since it appears that we have about 170 deaths in March and April, which would not normally have been expected. Has your organization seen any evidence of excess deaths due to lack of medical care for anything other than COVID-19 over the past 2 months?
Thank you very much for the question. I think there is certainly the immediate death that can occur, and we definitely have gotten.
Dr. Juan Rieger,
sorry. So we definitely have gotten, notices around immediate death where people could not get access to an intervention that would have in fact been a life-saving intervention. So that definitely has happened. What we're more concerned about, and we're trying to figure out a system to track, and maybe internationally as well, and that is the death that will occur later on because there was a therapy that was not provided. We've had patients that say, I need to get regular infusions. I'm afraid to go in for that infusion. So if I skip the infusion, what's going to be the impact? I think we definitely need to continue to track that. And unfortunately, certainly in rare diseases, we do not have that good of a system in order to do that. That's why we are also pushing very much for data registries and the ability to do it. So yes, immediate death and immediate further disability as a result of it. But I think down the road, we will see much more serious disabilities and progressive diseases that will also, be at the end of the day, the cause of due to COVID and not being able to access. And I don't know exactly how we can track that, but I think we need to, because if we have more waves of this, as everybody says, that is the king.
Right.
Thank you, Ms. Jansen. We go now to Mr. Fisher. Mr. Fisher, please go ahead, 5 minutes.
Thank you very much, Mr. Chair, and thanks, folks, for being here. You can't think of COVID-19 without thinking about folks with underlying healthcare conditions. And in the age where information is king, accurate information is king. We did hear some witnesses today use words like fear and frustration and speak about patients' fear of even going to the hospital. We know blood infusions, MRIs, people are not being referred to neurologists, oncologists. This can add to an already sky-high level of stress for some of these patients. So I'm interested in folks with respiratory issues, cancer patients. What is life like for some of those folks during the time of COVID-19? How are they connecting with healthcare professionals? Is it, I know Dr. Batani talked about telehealth. Is it online sessions? How do we, what is life like during COVID-19 for these folks? And I'll start with Lung Association, and then if there's any time left, maybe go to the Cancer Society. Thanks, folks.
Great question. So we're hearing that we talked about earlier about telehealth being a great tool. I know a number of physicians are making themselves available for telephone and video conferences. I mentioned earlier, we've hosted a number of webinars and Q&As on our website where we've had respirologists and healthcare professionals answer the questions of those on the video. And then for those remaining questions, because it was only an hour, we've actually had them respond to the questions we received and then send them directly to those patients. So we're encouraging them to use the tools, but we're hearing the same thing. There is some stress from mental health issues. We're encouraging them to manage their overall health. So make sure you're exercising if you can, getting your sleep, making sure you're eating properly. And then if you're on medications, make sure you're complying with your plans to best manage your health.
I'll just maybe add to that. I think, I've done a number of telehealth clinics and phone clinics with my patients. And, the respiratory patient is like any one of us. There's a lot of anxiety about what they should and shouldn't do. How are they going to, sort of just manage the activities of life, going for groceries, getting their prescriptions and adapting to this. So I think the stress and the anxiety of that is certainly, as much as it is for anyone in the country. But I'm going to say that, I think the resources that the Lung Association and the Canadian Thoracic Society provided are allowing them to cope as best as they can. So, there's videos that we've developed for at-home exercises and online resources for them to read and maybe become more educated about their lung disease. We've also promoted, lots about people who are sort of considering to stop smoking. This might be a good time because the social circumstances aren't there where you may want to go and have a cigarette. So if you're ever contemplating going to consider smoking cessation, maybe this is the right time to do it. So we're trying to work with them on an individual basis. But I would say that, at the end of the day, they're like any one of us. They're nervous. They want life to go back to as much normal as possible. But they're actually been very compliant with what the public health agency is saying. They're trying to avoid social circumstances that might put them at higher risk. So I'm actually very impressed with some of the responses that I do see from my patients.
I think the other piece, if I may jump in,
okay. I know that we were going to go to Ms. Seal, but if you have something quick you wanted to say there, go for it.
I just also think the way that they're getting care is very different, even when you show up at the hospital. So, today, for example, when you're talking about stroke, we talk about door to needle. If you are a candidate, sort of the clot busting intervention, what we would aim to do in 45 minutes to save as many brain cells as possible when you have a major stroke, now can take twice or 3 times as long with a number of serious consequences. So to the questions earlier about, never mind the impact of COVID, but COVID, the way that hospitals are managing very beautifully with precautions, but still there's other consequences that may have knock-on effects, more disability, more death, more complexity.
Cancer Society?
Yeah, thank you. I would echo everything that's been said. I think for cancer, there's such a feeling of powerlessness when you are diagnosed with cancer that you need support in the best of times. And what we've been hearing through our helpline and through we have a community called cancerconnection.ca where people go and support each other, patients and caregivers, and share their experience, is a kind of a frustration that they can't get answers about what's going to be next for them, which is very understandable because the healthcare system is just in the right now trying to determine how it's going to kind of reopen and resume services and get back up to the levels of care that people need. But the anxiety is very high, and I think it's for us it's meant that we're more relevant than average people, that we're not part of the healthcare system. We're not funded as part of the healthcare system. We're funded purely by donations that people from across the country contribute to help each other. And I think it's really pointed out the importance of that kind of second part of the healthcare system that keeps a lot of things going, that takes the pressure off of government-funded healthcare, but that is really a lifeline for people when they have nowhere else to turn and they have to deal with the inadequacies of our system. But the anxiety is there, and I think it's going to be there until we start to see the backlog being dealt with.
Thank you, Mr. Fisher. We go now to Mr. Theriault. Mr. Theriault, please go ahead. 2 minutes and a half.
Merci, monsieur.
Thank you so much, Mr. Chair. Mrs. Seal, on December 9th last, 2 survivors of cancer, Mrs. Dubé and Mrs. Sansfasson, and joined us to ask the government to act. We asked for a meeting with the Prime Minister to have more health support this is crucial to have some kind of benefit, health benefit, therapy that is not that doesn't create undue anxiety financially, anyways. When we started these talks, we were talking of at least 26 weeks. We proposed 52 weeks. These people did contribute to the employment insurance, and when you're sick, you want to have these benefits. What can you tell us about that? Would you agree with 50 weeks?
Thank you very much for the question. Yes, we've been advocating for an increase to the employment insurance sickness benefit for a number of years now, and it currently provides 15 weeks of coverage. So when someone needs to take time off work, 15 weeks are covered. From a cancer point of view, and this is of course different for different diseases, but from a cancer point of view, we know that that's not adequate for the average length of time that a person needs to be off of work to receive cancer treatment. So we have asked for at least 26 weeks of sickness benefit, and would see that as being very helpful to those with cancer. Of course, more time would allow for people who are not the average and who have much longer experiences and need support. But the extension of that employment insurance sickness benefit would be very meaningful to people with cancer and other diseases, and would help address what I described earlier of that incredible financial strain that people feel when they're ill, and the strain that then puts on families and caregivers and their extended support network around them. So yes, we would absolutely be very supportive of an extension to the sickness benefit.
15 seconds.
Oui, 15 secondes.
Yes, 15 seconds. Well, it could also help if there's a relapse, because if you're so stressed when you're getting your therapy, of course, the results are not necessarily as positive as you want them to be.
Right. It's very often complex, and it's not just a matter of one course of treatment. This is sometimes many years of impact on a person's life. Absolutely.
Great. Thank you, Mr. Theriault. We go now to Mr. Davies. Mr. Davies, please go ahead. 2 minutes and a half.
Thank you. Mr. Cloutier, 2 weeks ago, you wrote in Policy Magazine the following: the NAILA report charted a clear course forward, but we only followed the roadmap part way. We created PHAC, but failed to maintain the necessary resources and processes to deal with an outbreak of the scale and scope of COVID-19. In your view, in what ways did we fail to implement the recommendations of the NAILA report, and what can we do going forward to remedy those?
Well, I think that, and I made reference to it in my article, that there was a report in 2006 which outlined a number of recommendations. And if you look at the list of recommendations that were made and how many of them were implemented, you'll see that many of them have not been implemented. And that is why I said if SARS was not the wake-up call, I would hope that COVID-19 will be that clarion call where you are going to address not only the failures and the gaps that existed during SARS, but also the same gaps that might still exist during the COVID-19. I'm particularly pleased that a task force has been put together, again, with Dr. Naylor, who is well-versed and well capable of analyzing the situation, and that I hope this time that the governments, not just the federal government, that governments will actually take this report seriously and try to implement all of the recommendations coming from this report.
Mm-hmm. Of those, that itemized list of suggestions that were not moved forward with, do any stand out to you that you could advise this committee would be priorities for us to address this time?
I think one was funding, one was coordination, better coordination between the provincial governments and the federal government. Those are the only two at this moment, but I could get back to you with the list and say which ones we thought could be done better.
That'd be helpful. Mr. Dean, you sort of, this is a good segue because you spoke of the need for information, and previous witnesses have called for federal legislation establishing mandatory standardized information sharing between provinces, territories, and the federal governments in cases of national health crises. Is that something that, in your view, you would support?
Absolutely, and not just beyond crises, but obviously ongoing care and management for chronic disease. As I said, we want to make data-informed decisions. That's the best use of our allocation of resources. So I think we need to start by building the database.
Thank you, Mr. Davies. That brings round 2 to a close. We start round 3 with Ms. McLeod. Ms. McLeod, please go ahead. 5 minutes.
Thank you, Chair. And of course, this is the first time I have subbed into both this committee or any virtual committees. And of course, my first disappointment is it doesn't have all the power that we would normally have. And, you know, certainly if we did, I'd be making a motion right now and supporting Dr. Kitchen's thoughts around the issue of the CEWS and the CERB, because it really is, you're paying money for one versus the other, and you get so much value out of the other. And I would love to have been able to make a recommendation to the government that, you know, they need to perhaps broaden that criteria. So I really appreciate that testimony, because I think you spelled out the case very clearly, and it can't be a motion of committee, but certainly, you know, I think as independent MPs, if we feel strongly about it, I think we should all take the opportunity to move that forward. My first question would be perhaps to Ms. Seal, the Canadian Cancer Society. It's a very tragic young woman who is dying of cancer, receiving care at home, and of course, no one's visiting her because of COVID. Is there any mechanism, and do you have access to PPE, proper equipment, or is it a system in place that people in palliative care, in their home environments or others, can have visitors? Because what a terrible thing to be dying alone at home without people coming to visit. So is there a system in place? Is there adequate protective equipment so that we can have those sorts of visits?
Yeah, it's very tragic, and we've heard same kind of stories of people having to be isolated from each other at times when you want to connect, and of course we've all seen the situation in long-term care homes. I think for the patients that we speak to, the families that we speak with, they're very respectful of the instructions from public health to self-isolate and protect their health, protect each other, and so they haven't been looking to access PPE that would otherwise be needed in the healthcare system. And I think they would, even in spite of how tragic and difficult it is, I think for the most part, we've seen just a great deal of support for wanting to ensure that the healthcare system has what it needs to care for the most number of people.
So if we had had an adequate PPE, if we'd had the storerooms that should have been filled with updated equipment across the country, if we had had adequate protective equipment in place for the healthcare workers, including in our long-term care facilities, is this something that you see as an organization that you might have wanted to support?
I think any kind of support that we can give to allow people to connect with each other right now is vital. It's what we're trying to do when it comes to our online and telephone support, you know, where people are able to connect that way, and so we've really augmented the kinds of offerings that we're making right now in terms of our website resources and our phone support. And people are certainly accessing them. So I think in the absence of being able to connect in person, this is people are accepting it and turning to those more virtual ways. But of course, it's not the same as being able to be with the people that you care about in person.
Okay, so again, had Canada been well prepared, then it might have been a little easier. My next question, you talked about sort of the, you know, everything on hold in terms of chemo, radiation, surgery, diagnosis, all being delayed, which of course is very difficult. Have you been able to do any quantification of that yet, or is it going to take time?
Yeah, it's definitely going to take time because as we've talked about in a couple of circumstances here, the data is not there. It's hard to get a picture of the experience, and it's also very much varied across the country, and different jurisdictions are taking providing different levels of care right now. There was a study from the Quebec Cancer Coalition where they surveyed patients and found that 61% reported that their treatment or their care has been interrupted to some degree. So it's certainly something we've heard on a fairly widespread basis, but we also do know that some of the most urgent surgeries have been going forward as they need to, and that depending on the resilience of the local health system, they're starting to reopen and treatments are starting up again in some places. So that's very good to see.
Okay.
Ms. McLeod, 10 seconds.
I guess I won't try and say anything more. Thank you, Chair.
Mr. Chair, may I make one comment?
Thank you, Ms. McLeod. I'm sorry, who's speaking?
It's myself. It's Mohit Bhutani, Dr. Bhutani here.
Sure. A quick answer to Ms. McLeod's last question. Please go ahead.
It's actually more towards her PPE question. I think the COVID has created a lot of complexity to healthcare, and that the situation you describe is very tragic. Obviously, the one thing to keep in mind is that for PPE, there's a donning, putting it on, and a doffing, and that takes a skill set to understand the processes of those things. So we've got to be very careful in terms of who has access and how they have access to those things, because it's actually in the doffing and the taking off of the PPE that most of the errors happen and resulting in transmission of infection. So to make it to the general public is an idea, but it has to be done with careful thinking and thought.
Great, thank you, Doctor. We go now to Dr. Jaczek. Dr. Jaczek, please go ahead. 5 minutes.
Thank you very much, Chair. And my question is for Monsieur Cloutier. I'm not sure if you remember Monsieur Cloutier, but we were supposed to meet Friday, March the 13th, when essentially all hell broke loose, and obviously we were not able to have that meeting. I would like to pursue the line of questioning that a number of my colleagues have been pursuing, and it's essentially you have recommended a pandemic preparedness council, a greater role for the federal government. You've referenced the fact that there was a Minister of State for Public Health. In fact, it was the Honourable Carolyn Bennett from 2003 to 2006 post-SARS. I was the medical officer of Health for York Region at the time, so I remember that vividly. In an ideal world, how would you see us going forward with all your experience of government in terms of organizing this pandemic preparedness council? What sort of authority would it have? It's all very well to talk about coordination and collaboration with provinces, but what compels provinces to comply? So could you just give us a description of what in an ideal world you would like to see take place?
Good question, and I'm sorry we missed our meeting on the 13th. The first is you have to start by saying to yourself that at this moment, the Public Health Agency Canada is often considered as the poor cousin of Health Canada. It has very little money. It has very little influence. It has, if it has a major issue during a crisis like this, it has to report to 2-3 people before getting to reporting to cabinet. So my proposal of a council is a suggestion that I had that it should not only be reporting to 1 or 2 people, but it should be reporting to a body of people who can actually make decisions very quickly about the country, not just about a province or a problem. Hello?
Did someone interrupt there? Carry on.
So it would be reporting to the Prime Minister or even reporting to Cabinet. So that would give it the authority, it would give it the visibility, and allowed to have access to decision makers across the country. The other thing too is I think there has to be a review of the relationship that the Public Health Agency of Canada has with the various provinces and how they work. I have to admit very politely that I think that the communications and the coordination exchange this time was much better than during the time of SARS. And when the government really wants to really act, they did very well by trying to get all the people around the table to discuss issues such as ventilators, PPEs. But for me, is to give it more power, some visibility, access to decision makers, but also the authority to be able to speak to the person who has to make the decision and not having to go through a number of levels before it reaches the top individual in government.
And so, in a post-COVID-19 world, assuming all has gone well with the enhancement to PHAC, as you suggest, what do you see in terms of a federal role in healthcare more broadly? You've talked about hospitals across the country being at capacity already. Wait times for procedures are lengthy in many provinces. Do you see, or how would you see that the federal government might want to ensure the ability, should there be another pandemic, that at least we have the ability to have some sort of surge capacity locally within hospitals, within public health units?
Well, I think at this moment they would have to look at the picture at this moment in terms of surge capacity, because we're lacking and we have problems in the area of surge capacity even before COVID-19. So the federal government with the provincial government would have to look at that carefully and say, what is the norm or the normal world that we have and our needs in terms of surge capacity? In addition to that, I think there's, as I said earlier, there's going to be another surge capacity for all those patients who have not received care or have not received their surgery. That is going to be an added surge capacity. So you may see hospital having the same problem or the same challenges that they have had with COVID-19, but maybe double, because COVID-19 patients will continue in any case. It won't stop tomorrow morning. It will only stop if there's a vaccine, and that won't happen until 18 months. So my fear would be for the governments to come together and discuss how do we address surge capacity in each of the provinces, because it does vary from one province to another province. But surge capacity is the biggest problem that a hospital faces every day when they're trying to treat patients.
So Thank you, Dr. Jackson.
Thank you.
We go now to Dr. Kitchen. Dr. Kitchen, please go ahead, 5 minutes.
Thank you, Mr. Chair. And if there is time, I will like to share my time with Mr. Weber. Dr. Butani, you talked about COPD and asthma and the issues about, in particular, talking about inhaler shortages. You mentioned that with salbutamol. And then you explained a little bit later why that was, because there's actually people storing it in hospitals in preparation for a second or third wave. We've also heard the shortages on issues, for example, like hydrochloroquine, which we know is a malarial drug, but because of its use with RA patients, lupus patients, again, issues that have been brought up about that. So I'm just interested, are you aware of or heard of any other shortages that may have been, and would they be related to this type of situation where it's being overused, or is it maybe a supply disruption?
Yeah, so thank you for the question. And so there's two parts to that question. So first is, I'm aware of any other shortages. So drug shortages are very common within the country, and Health Canada has a website called drugshortages.ca where all the up-to-date information is applied. So these are commonplace. I think what pharmaceutical industry sort of historically has done is ordered or procured a certain number of units of medicines based on historical norms. Things moved very quickly between January and March in regards to the pandemic, and a lot of the purchases from the hospitals increased in anticipation of what Mr. Cloutier talked about in regards to the surge planning. So I think what ended up happening was that the salbutamol MDI, which we use for patients on a ventilator, they say the hospitals stockpiled them. So it wasn't really patients, it was more hospitals stockpiling them, from what we can understand from the information, which was the appropriate response from a planning standpoint. The other complication with salbutamol is when you're on a ventilator, you actually have to use double the dose of the salbutamol, because a lot of the medicines is lost in the tubing of the ventilator. And so what you need to get down there, you actually have to administer double the amount. So that created a sort of a perfect storm between requirements from a hospital in terms of what they're planning for, and then not availability for patients. I think working with the pharmaceutical industry and Health Canada and the partners that I've identified, I think we've done a really good job in trying to resolve this. And so the concept of the salbutamol shortage is a bit nuanced. Yes, they're only getting 1 month's supply, and I think there was a discussion earlier regarding about the dispensing fees. They'll only get 1 month's supply of it. But in all honesty, if you're ideally managed with your asthma and your COPD as an outpatient, you should theoretically, by current standards, only need 1 inhaler per year. And so in reality, if you're using more salbutamol as an outpatient, you probably should talk to your doctor about your chronic management, because this probably needs to be improved.
Great. Thank you very much. Dr. Wong Rieger, and I realize you cover a whole bunch of rare diseases. I'm going to focus on just one and ask you just your comments, in particular on cystic fibrosis, and in particular the medication Trikafta. And I'm just wondering, just to hear your comments with the issues with the PMPRB, how do you see that impacting our CF patients?
Certainly, cystic fibrosis has been front and center in terms of trying to get access to Trikafta, which in fact has been actually considered the A+ therapy for patients with cystic fibrosis. But unfortunately, because of the PMPRB, the company has been very clear, we cannot bring it into Canada at this time. The impact in terms of our pricing would be such that it would not only not be would not be affordable for us, but it could damage us further. And I think this has created a huge problem. They're not the only patient organization, not the only disease that's impacted in that way, but definitely they've been able to raise that to a public awareness. And of course, having the young woman who died in Nova Scotia, again, we have no clear evidence that she would have been saved by Trikafta, but she was definitely the patient profile that would have benefited from it. The other thing that happens, of course, is that we didn't get the clinical trials in Canada. And again, early on, there was the recognition that this was not going to be a country where we're going to bring this in early. And unfortunately, because of the way the system's set up, if you got the patient on the clinical trial, you can't just drop them. And I think companies are not willing to risk the fact that they may have to either keep a patient forever or for many, many years. And this is reverberating through many of our rare diseases, including, cystic fibrosis.
Thank you very much. Mr. Weber, over to you.
10 seconds.
Okay, thank you, Dr. Kitchen. Very quick, 10 seconds. Dr. Wooters, you alluded to organ transplants very briefly. Are you seeing people dying because they're unable to get organ transplants because it's all been postponed? Obviously, people are dying because of that, I would think. Any comment on that?
Yeah, I mean, it's having a consequence, like all the consequence of stopping elective activity. We have a very large lung transplant program that has essentially been put on hold, and there's lots of people waiting for lungs. There's lots of people on those waiting lists, and every day that goes by, there's a risk to everyone who's there and waiting for that. So it's a secondary consequence of COVID. It's not limited to transplant patients, but they are definitely part of that collateral damage.
Thank you, Mr. Weber. We go now to Mr. Kellaway. Mr. Kellaway, please go ahead. 5 minutes.
Thanks, Mr. Chair, and hello, colleagues, and thank you for the witnesses for some great testimony today. It's a real privilege. I was sitting here thinking it's a real privilege to be here to listen to a lot of the recommendations from the witnesses today and the past witnesses via Zoom. We've heard over the course of the last 6 or 7 weeks that research matters, health investment matters. MP Jessic talked about the theme of a stronger role for the federal government, and that's coming from the witnesses, and even among us as parliamentarians, hearing from many that investing in healthcare is essential. So it's just great to hear that. My questions will be focused on the Cancer Society, and this one is close to my heart. My mom has stage 4 cancer. She's had it for 6 years, and she was a former volunteer for the Canadian Cancer Society. So I know, vividly how the disease affects individuals, especially during this time of pandemic, in terms of the impact it could have on an immune system and a compromised immune system. And so it's a double anxiety. Can you tell the committee what kind of COVID supports you're offering to Canadians and their families impacted by cancer? You talked a little bit about it, but I think it's important to talk about some of the specific things you're doing right now with respect to those families and those individuals impacted by cancer as it relates to COVID-19.
Sure, thank you. And I'm really sorry to hear about your mother. And lovely that she was a volunteer with us. We have 100,000 people a year volunteer with the Canadian Cancer Society. It's an amazing grassroots network of people who all care about cancer and who do a lot to support each other and all the million plus Canadians living with cancer. So for us during the pandemic, because we've really had to switch away from some of our offline supports that we typically give, we've augmented the online. And so our cancer helpline is probably our simplest way that people are accessing support. And our online community called cancerconnection.ca that has so many amazing conversations happening between cancer patients themselves and their caregivers, people who are going through things right now that are giving each other tips, giving each other support. We've also created things like webinars, as some of the other organizations have mentioned, specific information about if you have cancer, what does COVID mean for how to navigate the healthcare system, how to understand the impact on you, how to protect yourself from the virus, and so all of these have been added services that we've created specifically for during the pandemic, and that we're seeing a lot of uptake of to just give people more facts and
Absolutely.
And a helping hand.
Absolutely. And I'll preface by saying my mother is actually doing very well, even with stage 4 cancer. She can outwork me on a given day. But the next question I have is for the Cancer Society, but it's also open to anybody that would like to answer it. As part of provinces and territories' response to COVID, many hospitals obviously had to cancel or postpone at least non-essential surgeries. So how does this impact Canadians with cancer or heart disease, or whatever the case may be? And I'm looking for priorities and recommendations for hospitals that are now resuming these canceled procedures. What would you recommend as a priority in terms of hospitals as we gear up to take on those non-essential surgeries?
Well, so I think opening up the levels of care as quickly as possible is what's going to help our cancer patient community most of all. The decisions that they're making about how to prioritize, I leave that in the hands of the healthcare leaders to do that well and to follow some of the guidance that has been created by organizations like the Canadian Partnership Against Cancer and the Surgical Oncologies Associations, who have provided more prioritization guidance. I did want to just mention on the thing that really helps people long term is research. And so while we have these immediate needs that people face, there is also the larger question of research and what's happening to research that we've talked about today. And I just wanted to say that as a funder of research, the request for the wage subsidy program to cover researchers is very important, because we see the investments that we make into research and the donations that people have given to us that go towards research, that maintaining those research teams is vital to that long-term outcome. So we've also been a part of the more than 40 organizations who've been calling on the government to please consider opening up the wage subsidy program to cover hospital-based researchers. We see it as essential for that long-term health outcome for Canadians.
Fantastic.
Thank you.
Can I just jump in there, because I think it's such an important question, but also one that for the rare diseases community has become a disproportionately difficult, because you get treatment guidelines for the more major diseases. And, but in fact, I mean, for instance, we have a patient that was waiting for a kidney transplant, but because he's not in the same category as other transplant patients, he gets put aside. We have a patient that's waiting for a microradiation therapy. Again, it took a lot of advocacy to get her in at the same in the same way that a patient with another cancer has. We have recommended there needs to be a parallel task force that would be made up of experts, but also include, though, from our point of view, many of our specialists who are able to put the patients into a proper triage. And I think as we anticipate another wave, we really want to do the things that you're recommending. How do we set up the ability to handle these other patients so that we don't end up with a backlog? But our fear is what happens a lot of times is the more common conditions, the better known conditions, they always end up getting the priorities because people don't know the others, they don't recognize the risk of the others. So we need to have a task force that can put all that into perspective.
If I can comment on this, I think the one thing this committee needs to know is that as we start to loosen up the criterion and as we start to go into elective surgeries, we got to be prepared because the COVID is not going anywhere. Let's not fool anybody. We need to be prepared in terms of testing, in terms of contact tracing, because if the load starts to increase and we start seeing signals of increased hospitalizations, increasing numbers, we're going to set ourselves back very carefully, significantly. And so all the things we've talked about today, we set back even further. So I think the one thing is testing and contact tracing, and every province needs to be prepared for that and do that in the right way in order to prevent this from recurring again.
It's a marathon, not a sprint, that's for sure. Thanks for the answers, folks. Appreciate it.
Thank you, everyone. We go now to Mr. Thériault. Mr. Thériault, please go ahead. 2 minutes and a half.
Merci, Monsieur le Président. Alors, ma question, Thank you. My question is for the Canadian Cancer Society. Monsieur Mazitsi or Madame Singh. Gouvernement fédéral
At recommendation 6, you say that the federal government should show more leadership and face inadequacies for anti-cancer drugs that you can take at home. Can you talk about this problem further?
Kelly to speak to this one.
And hopefully my audio works this time. So in our country, we face inequity across the country with how cancer patients have access to their cancer drugs. And we know that patients today want to be in their home. We hear this over and over again. And take-home cancer drugs, and I also would love the physicians to jump in, but take-home cancer drugs are available to patients across the country for them to pick up at their pharmacy and take at home. It's specifically oral chemo cancer medication. And we don't see this adequately addressed across the country. So for example, in some provinces, this is covered if you pick up your medication and pick it up in the pharmacy and take it at home. In the province of Ontario, for example, if you are taking your oral chemo in the hospital, it's covered, but if you go to the pharmacy and pick it up yourself, it's not. And so it again speaks to that financial burden for cancer patients. So we see that there's a role for the federal government to work with the provinces across our country to address this issue of take-home cancer drugs. And we'd like to see that cancer patients don't have to pay out of pocket, that it would be something that is covered equally across the country so that all Canadians have access to take-home oral cancer medication without having to pay out of pocket for it.
Mr. Thériault, you have 30 seconds.
J'imagine.
Excuse me, Mr. Chair. I suppose that during a pandemic, this problem is exacerbated, right? It's more acute.
That keeps people out of hospitals is beneficial at this time, and we've certainly seen that people have self-selected to stay away from hospitals, and that the strain there means that I think supporting more at home, more virtual, all of that will make sense in terms of reducing the strain.
Thank you, Mr. Thériault. We go now to Mr. Davies. Mr. Davies, go ahead. 2.5 minutes, please.
Thank you. Dr. Butani, there's talk across this country now about reopening parts of our economy and parts of our society. I'm just wondering what advice you'd have to the committee. What are some of the considerations we should be looking at? What are the guidelines or guideposts that should guide us in terms of having a health-based and rational approach to reopening?
Thank you for the question. And kind of what I alluded to a little bit earlier is that I think testing is really the key piece here. until a vaccine becomes available and we can inoculate a population to help resist the infection from being developed in someone. We really just need to be able to identify very quickly and accurately, who has had it, who they've been exposed to, and work within a parameter of public health to, quarantine those patients if that's the scenario that's needed. I think it's very clear. I think we need to go at this very methodically and very slowly, because as you remember, this whole, everything we've gone through the last few months was to save lives and to prevent our healthcare system from collapsing. And we won't be any further ahead if we open the doors too quickly. We've got to do it in a very methodical way. And I think testing and contact tracing is really critical to all of this, and we really need to be prepared for this. I think we've alluded to this conversation a little bit throughout the afternoon here, is that every province has a bit of a different strategy. I echo Mr. Cloutier's comment that I think there should be a national strategy where everyone is sort of treated the same, and we need to be working towards that.
Last word to you, Mr. Cloutier. There's been a reference in this meeting and others of drug shortages in this country. And, Canada at one time had a public drug company, Connaught Laboratories. Is it time, do you think, for the federal government to look at reestablishing a national public drug company that could work with academic institutions, which, after all, provide a lot of the research that goes into new chemicals, to sort of help Canada perhaps address the chronic problem of drug shortages?
I think that, yes, it would be important to do that, but I think before actually establishing a company, I think you would have to have a national drug strategy to which all of the parties would be, and I'm not saying political parties, but all of the players who are involved in this should be at the table. I think it'd be premature to establish a company without having that strategy ahead.
Thank you, Mr. Davies.
Thank you.
I'd like to thank all the witnesses for sharing with us all of your valuable time and all of your even more valuable experience and expertise. I would like to also thank all the members for being here. It's good to see you all day by day. I would like to draw everyone's attention to remind them that the purpose of these meetings, what we are mandated to do, is to receive evidence concerning matters relating to the government's response to the COVID pandemic. So I know that we've touched on a lot of wide-ranging health issues today, and it's not uncommon that we do that. But I would really encourage the members to focus on the mandate that we have, which is to receive evidence relating to the government's response. So with that said, thank you everyone for your time once again and your excellent questions. And I declare the meeting adjourned. Thank you.
Thank you.
Thank you.
Thank you.